Great. So nice to see so many folks have decided to join to learn a bit about our topic today. I don't have any financial relationship connected to any of the models or techniques that I'm going to discuss, so nothing to disclose. This is just in the slides you'll be receiving via email. There's information on how to receive continuing education credits related to this presentation. I'm going to provide a very brief overview, which is just some information specific to treating adolescents with opiate use disorder and kind of grounding in why they're a slightly different population to treat. And then I'm going to talk about two models of psychotherapeutic intervention, community reinforcement approach and adolescent community reinforcement approach, and just give you kind of the very brief overview of these two interventions and the components that comprise them, because these are evidence-based models for treating an adolescent transitional age population with any kind of substance use disorder, but also with opiate use disorder. So starting with that overview, recognizing that adolescence is a significant risk time period for human beings. And some of the data is actually pretty concerning, pretty staggering when we think about it. One of the theories that's related to why this time period is such a risky zone for substance use engagement is because we know that substance use disorders have a heavy genetic component, 50 to 60%, depending on the study that you're looking at. And we know that in adolescence, some of those genes can start to express and actually change how a person's brain is working, which can then lead to later issues as adults. So recognizing that this is a particular vulnerable time period for people is important. It's also important to note that a lot of learning is taking place during adolescence. And so we can learn really effective ways of becoming healthy adults, but we can also learn maladaptive patterns of behavior and maladaptive means of coping with negative affect and difficult thoughts or stressful situations. And so a lot of that learning that can lead to later issues with substance use problems can occur. So we see a lot of correlations related to this, that about 90% of people who will go on to be smokers, to have an issue with nicotine, started before the age of 18. That's compared to 10% after. About 60% who will go on to have a cannabis use disorder started before the age of 18. And 25% across any substances started before the age of 18. That's compared to 4% if they start after the age of 21. So again, this is correlational data, but it really does suggest that this is a very vulnerable time period for people. Now, in terms of this concept that drugs can be a gateway drug and lead to other drugs, there is that's not necessarily true from a behavioral standpoint, but in terms of how people can develop sort of an affinity for a particular class of drug, we can see that that it can be additive from that concept. So for example, 90% of people who develop either a cocaine use disorder or methamphetamine use disorder were smokers prior to the age of 18. So what does that say? That says that there's something similar going on in how either those genes are being expressed or those pathways are developing, where if someone starts with a stimulant, it can then put them at more risk for developing issues with stimulants later on in life. Another note on adolescence and substance use disorder is that this is a really important time where people are developing, who they are as people and connecting to certain peer groups. And so it can be really difficult to know who's going to go on to develop a use disorder as an adult, because experimentation with substance use is actually pretty normative. I'm going to show you a graph here in a second. It doesn't necessarily mean that those people will go on to have a problem. And so how we treat this presentation is different than how we would treat adults, recognizing that there is going to be some level of experimentation or use, but that doesn't necessarily mean that it's going to develop into a serious condition. So we're kind of doing a risk assessment on an ongoing basis, where we're looking at all of the different risk factors and all of the different protective factors for that particular individual, for that particular family, and then making decisions for how we're going to intervene to be most effective. Because having kind of a hard line abstinence only approach to this population tends to not go over very well. And that most adolescents who have some level of substance use experimentation during adolescence, they will go on to decrease their use to healthy levels by their early to mid 20s. So here's a graph from SAMHSA that shows you that the highest use of illicit substances is kind of in that 16 to 17 age range, and then followed by 18 to 20. So we see that this is relatively normative for individuals to expose themselves to substances at this age. And so how we provide education, how we work from a prevention standpoint is really, really important to trying to capture those folks that may go on to develop a serious substance use issue. Another factor to recognize is that we talked about how it's a vulnerable time period because genes that are associated with use disorders are kind of getting unlocked, turned on, like various things are happening within the individual's brain. The brain itself is actually developing over the course of this period. And one of the most important parts of the brain that's developing is what's represented in dark blue in this graph is our frontal cortex. And that's the part of the brain that allows us to make rational decisions, to really comprehend consequences of our behaviors, to think through and problem solve, to be able to regulate emotion. So that's a really, really important part of the brain. And you can see that it really isn't fully developed until about the age of 25. So the younger a person starts to engage with substances, the less likely that they have a fully functioning brain, and a brain that's capable of making some of those long-term decisions, delaying gratification, moving towards the types of behaviors that are going to set them up for a healthy, successful life. So it's just something to keep in mind that when we're thinking from a treatment perspective, not only are we concerned about the vulnerability of their brain, but we're also working with someone who isn't necessarily thinking through some of the long-term impacts of their choices or the behaviors that they're engaged in. And so again, kind of that hardline abstinence-only approach isn't necessarily going to be accepted or tolerated by this population. The same thing with using like a fear-based approach. I know there's been a number of programs over the years that have really focused on kind of scaring straight or exposing adolescents to the consequences of their behavior, like this is what could potentially happen to you. But recognizing that those same anatomical structures that are necessary to really encode fear, to really recognize that they could die, that this has really serious implications, that's not fully formed yet. And so that's why any attempt to really talk about the risks with them or kind of scare them isn't going to land, isn't going to be very effective. So just recognizing those pieces, they're not thinking that they're vulnerable the way that they truly are. So now let's talk about some ways that you can actually treat this patient population, and two models of care. These are both psychotherapy programs that were developed specifically for the use of adolescents with a substance use disorder. So the first one is called community reinforcement approach. This actually started back in the 70s with a focus on adolescents with or actually individuals, not just adolescents, individuals with alcohol use disorder. And it has been studied for the past 40 years and shown really good efficacy for use with people with multiple diagnoses, people in an inpatient population, and specifically the adolescent population. So it's more than just a psychotherapy. It's actually a fairly comprehensive behavioral program that works to make modifications to the environmental variables of the individual to make non-use more rewarding and use less rewarding. So it really kind of gets out of any of the traps where we're dealing with having to the individual to have to be highly motivated or willing to make changes, to have be in a place of even ambivalence. So it's really cool because it's just focused on how do we shift and make things so that they are more reinforcing to not engage in that substance use. So here's the original book written by Robert Myers and Jane Ellen Smith, actually here at the University of New Mexico. How does it work? So it's based on principles of operant conditioning. So that means that that we are all influenced by certain environmental variables, right? The relationships that we have, the work or the things that we do with our day, hobbies, other enjoyable activities, all of these things are happening around us, and that they have an impact on an individual's life. And what we see as the condition worsens is that people will start to move away from these more pro-social or healthy interactions that are inherently reinforcing in the service of the substance use. And so what CRA really tries to do is shift that balance. So helping someone, concerned significant other, parent, guardian, person in that individual's life to really reinforce and create relationships, opportunities, enjoyable activities that prioritize and become more desirable than the use behavior. So it really tries to systematically eliminate what's reinforcing the substance use. And why this is so effective for adolescents is because typically they have a lot of influence with peers, with family members. Those relationship pieces are very very pronounced in their life. And so if we can involve those individuals, then we can actually influence a lot of their use behavior by shifting that balance and helping to positively reinforce their non-use. So it essentially just makes not using much more rewarding. There are multiple components because this is a behavioral program. They use a common behavioral technique such as a functional analysis, but they don't just look at the who, what, when, where of their use behavior. They also do one for non-use behavior. So that way you're always looking at both ends of the balance scale, right? You're looking at, okay, what are the contexts and the variables that are connected to when and how and who you use with, but also the same thing for a pleasurable activity or something that maybe you used to really enjoy doing. And then how can we start to de-incentivize one and start to re-incentivize the other? They also, instead of really coming at and requiring cessation of use right away, it has a harm reduction approach to what's called sobriety sampling. And so that just says, we set windows around where somebody can have a period of non-use, and then over the course of care, try to increase that amount of time. And so it may be as small as just 1 hour before and after the therapy session, or 1 hour before and after they do a practice assignment, or they go to the movies with their family, right? So it may be as small as just 30 minutes to an hour a day, or maybe even just an hour a week, and you start there, and then you start to expand that sobriety window. CRA can be used with medication-assisted approaches, and it very much supports that. In fact, it has a whole protocol for teaching concerned significant others how to reinforce medication use by connecting it to a pro-social engagement with the family member or with someone that they enjoy doing things with. So there's a lot of really cool stuff in here that you can pull out and use to really help people maintain their medication adherence. It has its own treatment plan. It has a set of behavior skills that are taught, job skills that are taught, social and recreational counseling. If somebody does have a slip and returns to high levels of use, it has a whole relapse prevention protocol. And then it has a heavy what's called concerned significant other involvement. So one of the benefits of using CRA, whether you're using it with adolescents or even with an adult, is that it really does allow you to bring people from their life into the treatment and to use that effectively. So just to go over some of these components that I mentioned very briefly, sobriety sampling comes in two different phases. One is where we get them to agree to that time-limited sobriety window, and then outlining the timeline for how they're going to accomplish this, and then expanding that window as you go. Like I said, it comes with its own protocol. Originally, it was developed for disulfiram because it was developed for use with alcohol use disorder, but you can use the same scripting with really any medication, whether you're trying to get someone to maintain compliance with their antipsychotic medications or mood stabilizers, or with their medication-assisted treatment. So you can use it with methadone maintenance or buprenorphine. And it's really been shown to be very effective at helping people reduce their opioid use and have less symptoms across the board. Their treatment plan, again, not just looks at, okay, what are the psychotherapeutic goals that we're trying to get, but also what is your overall happiness in life? What is your overall quality of life? And how can we start to focus on that? So not just looking at your use behavior, but what are the things that actually give you meaning and purpose? And so they regularly administer this thing called the happiness scale, which looks at on a scale of 1 completely unhappy to 10 completely happy across multiple life domains. And that can really help us to target the specific goals that we're going to put into as part of the treatment. And you can see all of those problem areas may or may not have their own goal outlined. So it really helps us to kind of think about treatment planning from more than a symptom management perspective, and really get at what are some of the things that truly help people obtain and maintain recovery. It has a behavioral skills component, which looks at specifically teaching people how to do effective communication. So how do we basically do reflective listening? So communicate that we understand what we were told or what we just heard, how we can take responsibility for our own behavior, and how we can actually offer to help the other person. So kind of like creating a reciprocal dynamic that's part of the communication skills. It has a domain where they focus on problem solving skills. So looking at, this is oftentimes an area that is underdeveloped or has yet to be developed, particularly in adolescents. So helping them to think through something logically, come up with multiple options that they can do, or multiple choices that they can take, and then making the best decision for them. And then practicing skills such as drug or drink refusal. So how do they start to shift that dynamic with peers or with people that maybe they are used to using substances with, and do this effectively. So these are some of the core skills that go with it. These are the components of the drug use refusal training. So how do I ask for support? Recognizing what my high risk situations are going to be. If I can't do it a little more subtly, how do I practice and role play actually being assertive with refusal, and then doing some cognitive restructuring. Job skills goes into how do I start to develop, whether it's volunteering or part-time work or some sort of vocational rehab, but actually moving towards that pro-social engagement that gives me a sense of purpose, that helps me get out of bed, that helps me feel connected to non-using social supports. So it goes through how to develop a resume, interviewing, how to get a job, how to keep a job. And then it also has a section that's focused on social and recreational counseling. So in that big picture, holistic perspective, we're more than just work, right? We're also, we need to play, we need to have leisure, we need to have hobbies, we need to have other things that give us meaning and purpose. And so it has a set of skills that go through how to actually develop that. What does that look like? So you can see the benefit to an adolescent population who maybe hasn't developed this yet, that this behavioral program could actually set somebody on a corrective track to learn the types of things that they need to be more effective at living a healthy life and avoiding some of the things that are going to trigger or keep them engaged in unhealthy using. And then they'd use functional analysis at the beginning and whenever there is any kind of increase in use. So that helps people to identify what are some of the early warning signs, what are my behavior patterns that lead to that increased use. And then if that does happen over the course of treatment, which is very common, then they have a behavioral approach to sort of dealing with it to not go into that abstinence violation. There's a whole section that also focuses on how to improve relationships. And so it has a component for people if they're in a romantic relationship, they can focus on how to improve that relationship, friendships, how to use their communication skills and problem solving skills in relationships, and how to basically just remember to be nice and kind and engaged with those around them. Now, the same approach has actually been developed specifically to adolescents. So you can use CRA with adolescents, but you can also elect to use this particular protocol, which is specific to adolescents and was developed, this protocol was developed for those with cannabis use disorder, but you can use the same model for pretty much any substances. And it has all of the commonalities to CRA, with one of the main differences. So you can see it has multiple of the happiness scale, the relationship counseling, all of the problem solving skills. The main difference is that it has a whole section on engaging family and caregivers, and that there's a whole protocol specific to the work that they're going to do. So the caregivers actually have their own sessions as part of this protocol. So it's not just helping the clients to engage in more pro-social activities and take responsibility and develop the skills that they need to maintain these positive, healthy relationships with friends and family. But it also pulls the concerned significant other caregivers aside and helps them to take some ownership of what could they do differently, how can they interact effectively, and how can they actually reinforce the behaviors that they want to see and ignore the behaviors that they don't, which is typically for most parents out there, it doesn't seem intuitive, right? That intuitively we kind of want to punish when our kids aren't doing what we want them to do. And so ACRA really helps parents to understand that doesn't work so well with adolescents. So what we want to be thinking about instead is how can I just really reinforce when they are doing well and catch it when it happens. And then when they're struggling with something and those negative behaviors present, as long as it isn't safety related, the optimal way is to just ignore it until it extinguishes. So it has a similar structure to CRA. It's highly manualized. And like I said, it has a number of sessions for the individual and a number of sessions for the caregiver. So you can see how that's set up. So that's all I have for this presentation. That was a very brief overview of these two different models. What questions do folks have?